Let's go ahead and get started, and people can join as we get going here. So, welcome and thank you for joining us this morning for our Medicaid Sustainability and LTSS in Colorado informational webinar. My name is Jennifer Larson, and I am the training coordinator for the Office of Community Living. We are recording today's session, and we'll post that along with the slides on our website in the coming days. You can turn on closed captioning and in the language of your choice using the controls at the bottom of your screen. And due to the size of our audience today, we will be using a feedback form to accept your questions and comments. And we'll go ahead and put that link for you in the chat. And now I will turn it over to Bonnie to start the presentation.
Morning, everyone. For those of you that I haven't had the opportunity to meet, my name is Bonnie Silva, and it is my honor to serve as the Director of the Office of Community Living here at Healthcare Policy and Financing. I want to welcome each and every single one of you and thank you for making time out of what I know are very busy schedules to spend a few hours with us, I think an hour and a half on this beautiful Monday morning. I want to start by just recognizing that the topic before us is a heavy one. I think any time that we're having to look at reductions, those are really challenging conversations. And I want to acknowledge up front that these rate and policy changes absolutely will have an impact on our community. And I really appreciate your ongoing engagement and collaboration as we move forward through new ideas, through implementation, as we all drive towards a goal of how do we make sure that we have a sustainable long-term care system here in Colorado. So thank you. I see you, and I know this is hard. If we can go to the next slide, I want to tee up sort of what we will be talking about over the next hour and a half. Can we move to the next slide, please? Because this is an informational only webinar, I'm going to make sure you understand up front your opportunities for public comment and engagement. And then I'm going to spend some time really walking us through the background, the why. Why are we in this spot where we are needing to make some really difficult decisions, talking about our state budget constraints, and then we'll go deeper and look specifically at LTSS. And talk about what is our sustainability action plans, and then walk through next steps with you. If we can go to the next slide, please. So as I noted before, this is an informational only webinar. And as Jen highlighted, we're not leveraging the chat feature as this webinar will also be live streamed. We wanted to make sure that we had a uniform experience for everyone participating today. To that end, if you have questions, if you have feedback, the chat form that we're going to put in the chat form we will put in the chat. Oh, words are hard. The form we have to gather public feedback will be put into the chat. Thank you. I encourage you to use that. We also have that on our OCL sustainability webpage. If you don't have the ability to grab it now, don't worry, it will be posted later. Today's webinar will focus on the changes that were announced in the governor's budget on October 31st, as well as the actions that were taken during a special session in August. We want to make sure that we're building that bridge for you so you can see holistically what are the actions that we as a state are looking at taking. If we can go to the next slide, please. So back to my promise of understanding your opportunities to provide, public comment. Today's webinar, as I mentioned, is informational only. We know that people learn and understand information in a variety of different ways, and it's really hard to impart the story of why we are doing something through a fact sheet or our webpage. So my goal today is to provide more context to all of you around the actions that we have taken and the data and information behind those actions. Hearing from you is equally, if not more important. So we have scheduled a series of 3 listening sessions aimed at understanding the things that we should consider as we're looking at implementing these policy and payment changes. I also want to highlight for you that some of these reductions will require rulemaking, and so we have rule review on the IRSS, or Individual Residential Services and Supports rate alignments, slated for November 20th. And then some of these changes will require waiver amendments, which give you another opportunity to issue your public comment. So while this is a little outside of what OCL typically does, stakeholder engagement really is at the core of what we seek, and looking at feedback as even before we're proposing changes. But as you'll understand in the coming slides, we are really at the precipice of an incredibly challenging fiscal situation for our state, and it is essential that we move as quickly as possible in instituting these payment and policy changes as a way to mitigate, the need for deeper and more significant changes down the road. If we can go to the next slide, please. So I also want to point you to where you can find these resources. We certainly encourage you all to check out our Office of Community Living, LTSS Medicaid Sustainability website. We have fact sheets on all of these reductions on this website. If you haven't already, I would encourage you to sign up for our OCL Digest newsletter. It is our intention to take the information that we're receiving in that form that I just talked about, and to theme that information and to create FAQs and to send those back out via the newsletter. We want to make sure that we are being transparent and open with what we're hearing, what we're learning, and how we're incorporating that into our operations. I also encourage you to visit our OCL stakeholder engagement website if you haven't, and as opportunities to engage maybe on individual policy or payment changes arise, those opportunities will be posted there. And again, just want to highlight the importance of that form. It's just one of many ways in which you can provide us feedback. If we can go to the next slide, please. Right, so I'm going to start by laying the foundation around our state fiscal context. So I'm sure many of you have heard that Colorado consumes 1/3 of our state budget. And revenue growth is limited by TABOR and other fiscal constraints. TABOR grows at about 4.4%. And then we, on top of that, had some federal policy changes, particularly in HR 1, that are increasing the state's obligation towards our general fund. What happened in HR 1 specifically is that there was a reduction in revenue coming to Colorado because of tax changes within that bill, necessitating the special session that we had this summer to immediately bring our state budget back into balance. That said, we have a structural budget deficit. And so without action, Medicaid and LTSS costs will outpace other revenues, which means we will require nearly every single new general fund dollar to be dedicated towards Medicaid. That means no money towards education, public safety, for example, other key priorities for us as Coloradans. So it certainly is essential that we can bring our overall trajectory of spend more in alignment with the funding that we have available. If we can move to the next slide, please. So this slide shows a couple of different things. Again, as we are looking at increases in medical inflation, increases in benefits, as we've increased our coverage, you can see the trend for Medicaid has, between 21 and 22, and this forecasted this fiscal year, that we have experienced double-digit growth in our overarching expenditures. Again, if we look at if we look over the last 10 years in total, if we look at between 2014 and 2020, we were growing at a rate of 5% annually, so year over year. And again, with the investments that we have made over the last 5 years in particular, that 5% trend has jumped to 19%. If we go back to what I talked about in the previous slide, if we have TABOR revenue growing at 4.4%, general fund dollars growing at 5.5%, a 19% year over year trend is simply unsustainable. I want to highlight that, with all of this growth, 4% of the Medicaid budget is admin, with 0.5% going to staff. So while we have over the years, because of our passion and dedication for this work, tried to continue to operate very lean, we all must sort of look at holistically how we can do this differently. If we can go to the next slide, please. So as we're looking at how we climb this mountain that is before us, we looked to all of you to help craft a framework around, what are the priorities that we need to consider when moving forward. And the first one is we have to address the drivers of trend. I think one of the most common questions I get is, why isn't the state just taking an across the board rate decrease? Everybody takes a haircut. There isn't one population or one service that is maybe disproportionately impacted. The challenge with that approach is all that does is lower our base. And if we don't take the actions necessary to drive what is actually, increasing our trend, then we're going to continue on this hamster wheel of having double-digit trends, but it just might take us faster to get to the point that we are, taking all of the general fund dollars. So we really want to take the actions that are aimed at how do we bring that trend more in line with the funding that's available. Of course, we're always looking at how we can maximize federal dollars within the Office of Community Living. That has been evidenced through our use of and recent implementation of Community First Choice. We also have a Money Follows the Person program where much of the services are 100% federally funded. On Community First Choice, we'll highlight we have a 6% enhanced federal match there. And once fully implemented, it is slated to save the state nearly $30 million ongoing. So very big deal. We want to invest in Coloradans. This is sort of an outside of Medicaid goal, making sure that people have the resources and opportunities to, have access to health insurance. We want to make sure that we are making reasonable cuts or adjustments. So we have analyzed our benefits and looked at maybe where our reimbursements or our policies are not typical or out of alignment or associated with the trend that we simply can't afford, and have looked to make actions to bring them more into alignment with what you might see in another state Medicaid agency. Our goal here is to avoid draconian cuts, to maintain access to these critical services. And that certainly means in many cases pulling back. And I just want to acknowledge, I know that is hard. We're reassessing new policies, so things that haven't yet been implemented. You'll see us taking action to pause or stop entirely the implementation of those benefits. It certainly is much harder to take away something from somebody who is already receiving that service than it is to not give it to them in the first place. So that certainly is a strategy for us to consider. And then, we are working collaboratively across our communities to make sure that we are, being really thoughtful when we're looking at any level of increasing in rates and sort of long-term, what does that do to our programs? If we can move to the next slide, please. All right, so this slide is specific to the Office of Community Living. And it shows that between 2021 and 23-24, we have had a 44% increase in our costs. And I think that, you often hear the phrase of, budgets reflect values. And I think that 44% increase going from 2.9 billion to 4.1 billion is a reflection of our state's significant, and I think, investment in, dedication to the disability and older adult communities, their families, and the providers that support them. When we look at where is that funding going, nearly 50% is rate increases. And that is rate increases aimed at, building the base wage to meet local minimum wage requirements. They are across the board provider rate increases. We've certainly done some targeted rate increases. And we've had some statutorily required ones as well. But, it is my sincere hope that on this foundation of significant increases that we will be able to, work together to really figure out where the reductions need to happen in a way that minimizes the impact on the people providing the care. Next up, you can see is nearly 40% of our increase is due to utilization. And we'll talk a little bit more about the services specifically where we've had very high utilization. I will say within that 40%, over 70% of that is coming from long-term home health and in-home support services, or IHSS. We've also seen that the per member utilization has increased for those services by 33%. So again, I will go a little bit deeper in the coming slides so you can see the trends in the data that we are looking at to inform the decisions that we're making. And then enrollment. And when we look at sort of where people are enrolling, we can see that people with more complex health needs or more expensive waiver programs, that is where we are seeing higher levels of enrollment. So for example, our developmental disabilities waiver or DD waiver has an average cost of $98,000 per year versus EBD, which has a $36,000 average cost per year per person. And so the skewing is towards the DD waiver as a for example. And you can see that that is in part because the Joint Budget Committee has prioritized nearly 800 enrollments from the waiting list into the DD waiver. And that is on top of the work that we've been doing to make movement on the waiting list and to enroll people who meet emergency criteria or the youth transitions bucket. So I will talk a little bit more about those when we get into our sustainability action plan, but wanted to give you the 70,000 foot view as it pertains to OCL and what is driving our trend and how do we work together to address that. If we can go to the next slide, please. All right, so next up, I am going to talk specifically about OCL and long-term services and supports and give you a little bit more insight into how things are trending and why. If we can go to the next slide. So one of the statistics that you'll often hear folks talk about is that the long-term services and supports, or LTSS population, is just 5% of the people served on Medicaid, but consume 42% of the overall spending. On the one hand, I want to normalize that. It is typical across the nation for the small portion of people receiving LTSS to comprise the vast majority of spending in a Medicaid budget. That makes a lot of sense. Serving people with disabilities and older adults is really at the heart of what Medicaid programs are designed to do. And appropriately so, long-term services and supports can be very expensive, but it also places, because of that, perhaps a disproportionate amount of responsibility to make sure that the LTSS programs are growing at a rate that we have confidence that can live within our cost envelope, which means we have confidence that those services and programs will be available not just a year from now, but 5 years from now, 10 years from now, 20 years from now. We want to collectively make sure that we have sustainability at the forefront of our plans. When we look at, how our programs are growing, you can see that there's significant growth in children's programs and children specifically that have higher needs. And so I'll talk a little bit more about that in the coming slides. Also, we are looking at the aging of Colorado's population. I think we toggle between second or third fastest aging state in the nation. And for the first time in ever, people with really complex health needs are aging well into their 80s, their 90s. And so when I talk about sustainability, it's also with an eye towards the demographics. People with intellectual and developmental disabilities, thankfully, are, now projected to live. I think our population is looking at more than doubling over the next, 10 years or so. So, workforce challenges and rising wages continue to elevate provider costs. We have, again, made significant investments in this, but now is the time that we want to work together and make sure that we can build off the amazing program that we've put together and have a good path forward for our future. If we go to the next slide. So when we look at our home and community-based waiver programs, and I'm going to give you a deeper lens into that in just a second, we can see that there's significant enrollment, and that not only are people enrolling to these programs, but once they're enrolled, they are utilizing significantly more services than they have in the past. And so what we know is if we take no action, we will exceed all available funding. And again, I want to go back to the sooner we can approach and address what we are seeing as unsustainable trends, the less deep reductions and changes we have to make. And so that is why you see us moving so quickly. If we can go to the next slide, please. So this slide highlights our growth and increased and per member per month cost. And, you can see this across some of our key waivers really aimed at supporting people. Our brain injury waiver, for example, has had an enrollment growth of over 35% and over 41% increase in per member per month. I want to highlight for you that the children's programs, the Children's Extensive Support, and the Children's Home and Community-Based Waiver Services Program, or CHCBS, which has now been combined into the Children's with Complex Health Care Needs Waiver, triple-digit growth in how much service people are using once they're enrolled, and that's on top of double-digit growth in enrollment. And, you can see double-digit growth for the complementary integrative health waiver, for the DD waiver, and for our EBD waiver. So this gives you an idea of the type of enrollment and expenditure increases that we are seeing really across multiple populations and waiver programs. Next slide, please. So when we dive a little bit deeper, so, we talked about Medicaid as a whole. We talked about waiver programs within Medicaid, and now we're going to look at services. And these are the services that are primarily driving the trend across the Office of Community Living. Community Connector is a service that, obviously we are taking multiple actions around. And part of that is that we have had a triple-digit 620% increase in the paid amount, with a nearly 50% increase in the number of hours members are requesting and receiving. In-home support services, we've 260% increase on top of a over 30% increase in utilization. I will highlight that for long-term home health, we are recently in the process of turning back on the prior authorization requirements, and we expect that to have an impact. But you can see we had an over 83% growth in the paid amount of services for this. And then if we look at just personal care and homemaker, non-consumer directed, we've seen significant spikes there, over 70% and over 23% for how many hours people are utilizing. So you can see, we are looking at our data, we are trying to understand how do we maintain access to these critical services, but do that in a way that we have better assurance that we can afford it. If we can go to the next slide, please. Okay, so this slide shows the rising cost trend. And you can see that it's grown really at a fairly rapid rate. Over the last several years, the year-over-year growth has gone as high as 19%. This is total cost of care increases. We can see that the primary driver of these trends, as I've articulated on the previous slides, really are the LTSS services. It's not LTSS members utilizing emergency departments for example, or LTSS members utilizing primary care. We can see that it is the LTSS services that are primarily driving the increases. If you can go to the next slide, please. So if we look at our continued spending growth that's forecasted, this slide is particularly impactful for me, and I hate a number slide, so just please stay with me for just a moment. So for our fiscal year 26-27 forecast, we are looking at needing, for just the Office of Community Living, $378.1 million. Because we've taken the sustainability actions that we've proposed, we can subtract out 161.96 million, but we still are requesting in the governor's budget 217.2 million to continue to maintain much of what we need to move forward for these critical services. If we can go to the next slide, please. So now in this section, I am going to spend some time talking through our sustainability budget actions, and hopefully I will do a good job of tying back to our framework and the trends that we're seeing and why the action was prioritized. If we can go to the next slide, please. I want to just call to your attention, there's a little logo in the upper left-hand corner. This black one, it says it's the governor's budget. What we're just trying to do is better delineate between what is in the executive order versus what is in the governor's budget, for those of you that care and can better track that. So when we look at the governor's budget that was released on October 31st, his proposed budget for 26-27 for all of healthcare policy and financing is 20.6 billion in total funds, and that includes about 5.99 billion in general fund dollars, and this is representing a 2.3 billion total funds, including 413 million increase in general fund. So while the sheer amount of reductions might feel significant, I want to highlight we're still asking from our legislature for them to prioritize a significant amount of funding for healthcare policy and financing so that we can ensure that services continue. I want to also highlight that 96% of those total funds that I just talked about are allocated to go to care. Like, that is out the door, making sure that care gets delivered. I would say that if we look at what is being requested to be allocated in fiscal year 26-27, it is 32% of all available general fund for the entire state. So again, even with our reductions, we are asking for a lot, but we are also, I think, really obligated at this point to lock arms and say, look, we recognize that there is a problem. We are here to help solve that problem and make sure critical access to services continues for the populations that we support. And so to that end, we have 18 new sustainability actions related to LTSS specifically, and this is in addition to the 4 that were announced in the August executive order. If we can go to the next slide, please. So we have linked here and in the chat, we have the governor's executive order that was issued on August 28th. That initiated 252 million in budget reductions across all state agencies, including 79 million specifically for HCPF, and there was 4 that were targeted to long-term services and supports. The executive order that was issued on October 31st initiated 13.5 million in additional reductions for this fiscal year. And again, timing is important here, and in that the faster we move, the less deep actions we have to take down the road. And HCPFs are also included as part of the R6 budget. If we can go to the next slide, please. So here, I'm going to go ahead and dive a little bit deeper on those 18 actions. I'm literally going to walk through every single one, so hang in with me. So the first one is, in addition to looking at, where we could make actual payment or policy changes, we also looked at where we had funding in our budget that could be moved back to the General Assembly to help us address the issues that were before us. So there was funding allocated to our skilled nursing facilities aimed at making sure that they could make sure their workers were also meeting base wage requirements. There was statutory language that said that once the minimum wage met $15 an hour, the dollars could be reverted. So we went ahead and reverted these dollars as part of the governor's budget. The base wage requirements for nursing facilities remain the same. Part of our justification here is the 1.6 reduction did not apply to nursing facilities, so putting these dollars back into the pot and asking them to continue to pay their workers felt like an appropriate and reasonable compromise, as we're all looking at how we can, come to the table and solve this problem. If we can move to the next slide, please. The governor looked to roll back the provider rate reduction that was effective in July. It was a 1.6 across the board increase allocated by the Joint Budget Committee last year. This helps us better align with our historical rate growth of like 0.4% annually versus the 1.6. It also balances the fiscal sustainability, stability, and provider sustainability. And this was effective October 1st of 2025. So we've already enacted this change. If we can go to the next slide, please. So I'm going to do Community Connector Part 1, and then I promise I'll do Community Connector Part 2. When we look back at what are our drivers of trend, this community connector service is a primary driver of our trend. One of the stats that wasn't on the previous slide is that 80% of all kids on the Children's Extensive Support Waiver are receiving Community Connector. So it is driving triple-digit trends, and it is for a lot of people driving triple-digit trends. So we knew that we had to take some pretty significant action, but we wanted to be thoughtful and create some space and time to ensure that we were taking the right action. So the initial 15% reduction was like, let's just immediately lower the rate to a rate that we knew was probably still too high, but would give us a little bit of time to really, evaluate what the long-term action should be, which will be sort of the Part 2 Community Connector, and allows the state to have some immediate savings given our fiscal crisis. So the initial 15 is slated to be effective January 1st of 2026, and we're sort of in the process of implementing that. If we can go to the next slide, please. So the next one is to align IRSS rates for family caregiver homes. So this was announced also in the governor's August order. And the goal here was to make sure that we are updating our regulations and our billing guidance to define settings and billing codes. This is an action that we've received a lot of feedback, especially from family caregivers themselves, indicating that this change, doesn't feel quite right. And so while it's important that we have some fidelity to, how our rate methodologies say that we should be paying for similar services, we've certainly received some really good feedback on how we can revise that regulation to better reflect how the services are actually delivered, help us bring that, fairness and consistency to how we are paying for services, but also, we can craft language that better reflects how the care might be delivered, and better provides guidance for when it should be billed at a higher rate to reflect the higher cost of bringing in rotating staff versus a lower rate to reflect the lower cost of having, a single, mostly primary care provider rendering that care. So we've gotten some good feedback. The team is working to incorporate that feedback and make sure that our regulations, again, better promote fairness and equity to how we are reimbursing for these critical services. This is slated to be effective in March. And this is, when we look at our Medicaid sustainability framework, there actually isn't huge savings here, but it is about where our policy is not in alignment and where do we want to make sure that we're cleaning things up to ensure that we are sustainable for the long run. So that is under that component of our framework that we are looking at enacting this policy change. If we can go to the next slide, please. So next up, we are delaying what is called presumptive eligibility. Presumptive eligibility is really aimed at making sure that we can, more quickly discharge people from, say, hospital or nursing facility settings into the community, people who are very likely eligible for LTSS, but not having to wait for them to go through the entire process in order to initiate that change in service. We crafted this policy with the insight of a lot of stakeholders and put it in what's called an 1115 waiver application. It's just a federal authority for how you might seek authority from the federal government to make this policy change. CMS came to us and they let us know that they are taking a 1-year sort of extension, which they're allowed to do, to review our application. So that means we don't need the money as we anticipated we would, because we're not implementing the change. So we are reverting those dollars to help, make sure that we are being responsive to the fiscal crisis. The delay is immediate, but we are still expecting and moving forward to implementing this change. It will likely not be until 2027. If we can go to the next slide, please. So next up, we are looking at changing the enrollment criteria into the DD waiver, specifically ending the ability to request a transition into the DD waiver solely based on being eligible and enrolled into the Children's Extensive Support or the Children's Habilitation Residential Program. So when I talked about the drivers of our trend, in many areas, it is the rate increases that are driving the increase in costs. In many areas, it's that increase in utilization, so utilizing more services than what we have in the past. For the DD waiver, it is the increased enrollment that is driving the trend there. And so you'll see us taking action to make sure that we can, continue to prioritize DD enrollment for the people who need it the most. And for those of you that may not be familiar with this waiver, it is a residential program for people with intellectual and developmental disabilities that provides access to 24/7 care. It is one of our highest cost waiver programs. So we are no longer going to allow for that ability to request just based off of, hey, I am in the CES waiver, I am in the CHIRP waiver. And sort of our compromise here is we are able to maintain our ability to enroll members who are experiencing an emergency. So we maintained our funding and authority to do that. People who are moving from an institution and into the community, we maintained our funding and authority to do that. And also maintain the ability to enroll youth who were in the child welfare system. And so, it is our hopeful between having the emergency criteria, the kids and child welfare, and, getting people out of institutions, that we're able to mitigate crisis before it happens and, secure those resources truly for those who need them the most. I know this is a really, I think, tough change for many people to hear, especially for those who have children on the CES or CHIRP waiver, who, his plan was to enroll into the DD waiver, and now we're going to have to work together to come up with a new plan. We are looking at having this effective next summer, pending CES approval. So we certainly will be taking a lot of feedback on how we can do this in a way that helps support members and families with this change in sort of their life circumstance and life planning. Again, I know this one's difficult, but it really is, I think, essential for us as we're looking at what sustainability actions have to be taken. If we can go to the next slide, please. So similarly to the, stopping the ability to request for youth in CES or CHIRP, we are also reducing the DD waiver churn enrollments. And so right now, the way that churn enrollment works is one person leaves the DD waiver, and then we enroll the person at the very top of the wait list. So one person on, one person off. What this change will do is for every 2 people that leave the DD waiver, we will enroll 1 person. So it is slowing the growth of enrollment into that waiver while still allowing us to prioritize some movement from that waiting list. This change is also effective, slated to be effective in summer of 2026. If we can go to the next slide, please. So the next one is to align member contribution to the DD waiver. So if we look at our Medicaid sustainability framework, one of the areas that popped out as not being in alignment, even within our own policies here in Colorado, was requiring member contribution for the DD waiver. As I noted just a few minutes ago, it is a residential program. We have several residential programs across our home and community-based service waiver system. We have residential programs in the ABD waiver. We have residential programs within the brain injury waiver, as a for example. And every member enrolled in those residential programs pay what's called they have what's called post-eligibility treatment of income applied, which means they're paying for a portion of their services. It's only in the DD waiver where the PEDI hasn't been applied and members haven't been paying for a portion of their services. So this is, intended to create consistency with other residential benefits, and make sure that we are being equitable in how we are implementing sort of payment policy across the board. This is also slated to be effective in the summer of 2026, pending CMS approval. If we can go to the next slide, please. So next up, we are looking at introducing unit caps for some HCBS services. I think that as we are looking at what is driving our trend, we can see that these services across a variety of service delivery options, meaning whether they're provided through an agency or self-directed options, have continued to grow at a rate and be utilized at a rate that we really have to curb down. So we are looking at having, and these are annual limits. I gave you the approximate hours per day because I think that's like easier for folks to get their head around. We have personal care at 6.5 hours, homemaker at 3, and health maintenance at 13. It would be highly unusual for a person to have the maximum amount of units authorized across all 3 of these services. It is essential that they're still, authorized based off of need. And when we do a data analysis, we can see that these service caps are quite generous. And that's when I say it would be, quite unusual to have people just maxed out at the very top of this tier. We would expect, again, authorization to actually be lower in many circumstances. We will have exception process to these unit caps for people who truly have extraordinary needs that just don't fit within these caps. We will have a process to review that rare circumstance and to make sure that those units are authorized if in fact they are truly what is needed. If we can go to the next slide, please. Next up, we are placing a cap on the weekly caregiving hours. So this limits caregiver hours to 56 hours per week per member. So that means a single caregiver cannot render more than 56 hours a week for an individual person that they're providing care for. The goal here is to make sure that there isn't an over-reliance on a single care member to render a disproportionate amount of care in a way that would lend towards burnout and lower quality services. And then in addition to that 56-hour per week per member cap, the 16-hour caregiver limit will also remain in play. So 56 hours for a caregiver to person ratio, and then as a caregiver, you cannot render more than 16 hours a day, no matter how many people you're providing care to. And again, that's just aimed at making sure that we have policies that drive towards sustainability, and we have policies that really, incentivize our amazing providers to make sure that they are pulling in and cultivating a workforce outside of, say family caregivers or people who are living in. We want to make sure that we have diversity of caregivers coming in. And, also helps us control costs. This is slated to be effective spring of 2026, pending CMS approval. If we can go to the next slide, please. Oh, and one more thing on the 56-hour week. Again, it's a weekly limit, not a daily limit. So we understand some people might do 12-hour shifts, maybe even 16-hour shifts, but it is across that week. It cannot be more than 56 hours a week. Thank you for that. If we can go to the next slide, please. Another area where we were looking at perhaps where our policies are more generous than what they are nationally is the allowance for legally responsible persons to provide homemaker services. So as a reminder, a legally responsible person might be a spouse, they might be a parent, or a legal guardian. Right now, those folks can get paid for up to 10 hours per week of homemaking services. We are reducing that to 5 to be more in alignment with what would be typically allowed across other Medicaid programs and policies. Again, maintaining access to the services, maintaining access to this critical workforce, but also making sure that we have some sustainability here. This is also slated at being effective in spring of 2026, pending CMS approval. If we can go to the next slide, please. Next up, this one is difficult too. They're all difficult. We are looking to reduce our movement therapy services to align with our rate methodology. When the rates were evaluated for movement therapy, it was demonstrated that we were paying higher than what other comparator states would pay for the exact same services. So you will see us reducing these rates in alignment with that recommendation, and this is effective in spring of 2026, pending CMS approval as well. If we can go to the next slide, please. And this is if we go back to the Medicaid sustainability framework, like we considered perhaps not starting things that have yet to be implemented. And this is an example of that. It will remove equine assisted therapy because it hasn't been fully implemented. There's no members accessing these services. And so we are removing that as a covered benefit. And this will be effective in September of 2026. Again, regretfully, we know this is a great service that has good impact for many people, but is much easier not to give people something than it is to take it away. Next slide, please. So this is Community Connector Part 2. I promised that it would be coming. You will see us taking several actions. So we further reduce the Community Connector reimbursement to align with Tier 3 supported Community Connections rate. So for those of you that may not be deeply familiar with these services, Community Connector is for children, supported community connection is for adults, but looked at, at what tier would one-on-one engagement be supported. And so we're looking at aligning the Community Connector rate, which, to be frank, was abnormally high and not justifiably so, with its analogous service in the adult world to make sure, again, we are being equitable and fair in how we are administering these programs while still maintaining access to these services. This is very necessary for the sustainability of the benefit and allows more comparable direct services. The rate reduction in totality will be effective in spring of 2026, pending federal approval. If we can go to the next section. So this is Community Connector Part 3. Hang in there with me. So we, in addition to reducing the rate for the second time, so in total it's a 38% reduction in the rate. But again, that reduction is in alignment with what we are paying for its sister service in adult waivers. We are also looking at reducing the annual cap of Community Connector services by 50%. This is an area where we again, our policy was more generous than what was typical, and it still, from our perspective, allows for quite a few hours of services to be rendered. We're going from 520 hours per year to 620 hours per year. And again, they're yearly limits. So if people want to save those hours up for the summertime where, school is not in session, there's an option there. And that is for both the CES and Children's Habilitation Residential Program. This will again help us drive what is driving our trend back down, while continuing to allow for this service. So this one is also pending CMS approval or federal approval and slated to be enacted in the spring of 2026. If we can go to the next slide, please. Right, and then the last community connector change that we are making is we are looking at limiting to this benefit to school-aged children, typically ages 6 through 17 with an assessed need. What we have found when really looking at, where is this benefit maybe not being utilized and authorized in alignment with our policy, we saw that most often for children under the age of 6, where, engaging in the community is typically the responsibility of parents, and certainly not by any means dismissing the difficulty of maybe doing that with a child with a significant disability. But the line between parental responsibility and paid provider was so very small that this felt like a reasonable approach to better proactively ensure that this policy is being utilized in alignment with how it is supposed to be moving forward. This is also slated to be effective in spring or summer of 2026, pending federal approval. If we can go to the next slide, please. All right, so next up, we're actually looking at adding something. I think that you have seen us take actions over the last few years where we create or add benefits aimed at actually reducing cost. And so one of the things that we are looking to do is to provide private duty nursing 60-day acute care benefit. This will help us more immediately get coverage for people post-hospitalization without having to go through the entirety of a prior authorization process. We are very hopeful that it will improve transitions from acute to home settings. So very excited to offer this additional benefit to, again, help keep people in their homes and keep them in their communities. This is slated to be effective in early of 2027. If we can go to the next slide, please. Next up, so we are now focused on what's driving our trend, also where are our payment or program policies not in alignment. And this is an area where our payment policies really required some further evaluation. We are proposing to add a per diem blended rate for private duty nursing when those services are provided 24/7. The rate for this per diem rate will be a blending of RN and certified nursing care, so registered nursing and certified nursing components. We are hoping that there'll certainly be a decrease if somebody was just billing RN, but we know that care is provided in a way that really doesn't care, oh wait, the RN is going to be here for the next 4 hours and then the CNA is going to show up for 1 hour. That often the level of care required is blended in how it's delivered. So we're truly hopeful that the decrease in administrative burden for providers will be offset by the decrease in the overarching cost and help us all gain some, I think, administrative efficiency as we're moving forward. The hourly unit, the group unit will remain available for when that's appropriate. So the per diem rate is on top of what is already available, and this is slated to be effective early 2027, pending federal approval. I think maybe now, really quickly, and I perhaps should have started here, so forgive me. You'll see that in the governor's budget, we announced actions that are not slated to take place for some time and some that are immediate. And our goal here, again, is to be as transparent as possible, to get in front of you as quickly as we can, to really outline, here's everything that we're looking at implementing right now versus, waiting and rolling these things out sort of in a more stair-stepped measure. So I hope you can see that. And the goal there, again, is for us to engage early and often where we can. So this is early 2027. If we can go to the next slide, please. The other payment policy that we're looking at changing is how long-term home health, both the certified nursing or CNA and therapy services, so speech, language, physical therapy, can be billed. We are proposing new billing durations to better align with how the care is actually delivered. So for long-term home health, we are converting what is now you can bill up to 2.5 hours into 15-minute billing increments. When we look at the duration of how long care is actually provided, it's much closer to the 15-minute unit increment. Of course, there is nothing that would prohibit a provider from billing multiple 15-minute increments if that is what the assessed need requires. But this allows us to better align our payment methodology with how care is delivered, and be more fiscally responsible with the dollars that we have. I want to outline the same thing is true for the PT, OT, and the speech and language. They also were allowed to bill for services up to the 2.5 hour mark, and we are looking at reducing that to 30 minutes. This is slated to be effective in 2027 early, and also will be pending CMS approval. If we can go to the next slide, please. All right. We are also looking at, you'll see we focused a lot on how we're paying for services and how we can garner some efficiencies there. So we will be creating group rates for certain community first choice and long-term home health services. We try to be mindful of when a policy change in one area will have an unintended impact in another policy area. And so you can see that wherever possible, we took a similar approach, whether it is long-term home health, community first choice, agency delivered, self-directed, like how can we bring some consistency to the changes that we're making? So for CFC and long-term home health, we are establishing group rates for services for health maintenance activities under in-home support services or IHSS, personal care, homemaker within CFC, and also for CNA services within long-term home health. What this means is you can have a single direct care worker or CNA to provide and serve multiple members at the same time or household kind of simultaneously. We know that this care is happening in group settings right now, and it just better aligns how we're paying for services with the administrative efficiency that is achieved when it is a group delivery, lending better towards long-term sustainability. If we can go to the next slide, please. All right, so next up, we have requested to create a standardized rate setting tool for our residential habilitation, specifically to make sure that we are more consistent in how we are doing this. It will develop a consistent rate setting process for negotiated rates. So within the IDD waiver programs, we have the option to create negotiated rates for people whose needs just don't fit within our funding algorithms. Our DD rate process was developed in the spring of 2026 is what we're looking at. And for the Children's Habilitation Residential Program, we are looking at that process to be developed in the fall of 2026, maybe early 2027. We are hoping that this change will promote transparency, predictability, and fairness for all of our providers. If we can move to the next slide, please. Next up is the Colorado Single Assessment Tool. So for those of you that have been around for a while, this has been a labor of love. We have been working with a core set of stakeholders to implement a single assessment tool and a corresponding person-centered support plan for all individuals seeking long-term services and supports. We have done so much work to implement this, and we are finally at a spot where over this next year, we are looking at piloting and starting the phased implementation of this new assessment and person-centered support plan. It's been so long that most people probably don't remember, but the Senate bill that required Colorado to create this single assessment, Senate Bill 16192, only provided HCPF with funding for the first year of our assessment tool. So this is why we were having to do a funding request to fully implement. The goal has always been for us to come back to the legislature saying, we've developed it, we've piloted it, here's what we know in terms of the funding that we need to implement it. Of course, it is a norm reference standardized assessment tool, and so it will bring a much higher level of fidelity to how services are assessed and authorized in our system. And so long-term really is a key strategy for our state. If we can go to the next slide, please. All right, so if your head isn't spinning yet, I want to talk through some high-level implementation timelines so you can see, at least from the 70,000 foot view, how does this all fit together? If we can go to the next slide, please. So these are things that we've already done. So this happened in the fall of 2025. We reverted the nursing facility minimum wage supplemental back to the General Assembly. The provider rate reduction reversion that happened in October, and we've also in October reverted the funding for the long-term services and supports presumptive eligibility. Now, if we can go to the next slide. This talks through a general timeline of when you can anticipate the other things being implemented. You saw me talk through on each slide, hey, we're looking at 2026, fall, spring, summer, 2027. But you can see that the initial community connector rate reduction and the IRSS changes are slated to be in first quarter 2026. Then you can see we have everything in blue here, soft caps on HCBS, weekly caregiving hours, capped on homemakers for legally responsible persons, movement therapy, the second community connector rate reduction, and then the community connector service limitations and age restrictions are the second quarter of 2026. The third quarter of 2026 will be the standardized rate tool that I talked about for residential habilitation, the enrollment changes for youth into the DD waiver, reducing the churn enrollments to the DD waiver, and also the requirement for a cost of care contribution for the DD waiver. Those are all in the third quarter of 2026. And then last but certainly not least, we have the PDN acute benefit and the per diem rate, the adjusting how long-term home health services are billed for and therapies, and then creating group rates will be in the first quarter of 2027. If we can go to the next slide. So I have just, over our last hour plus, gone over an extraordinary amount of information, but I want to just take pause and reframe, like, what are the key takeaways? The first is that LTSS costs are rising faster than the state revenue growth. This is not a want, it is a need for our state to look at how services are paid for, how they are authorized, what the policies allow to ensure that we collectively will have a sustainable long-term services and support system now and well into the future, as we know more people will need access to these critical services. I want you to look back to our sustainability framework that really we're looking to balance our fiscal and service priorities. I know that these reductions, these changes will have an impact directly on people, their families, their providers. I am hopeful we can withstand that impact based off the significant investments we have made over the past 5 years in particular. And you can see that we are really working diligently to take actions that will actually change that trend curve meaningfully and allow us to have more confidence about where we're heading. And to that end, it is the preserving access. We want to make sure that we are strengthening our system, that we have the vitality, the things that we're really proud of in terms of high quality, remain at our forefront and sort of be what we are driving towards. So impactful, yes, but we are really looking at how we can pull back some to make sure that those services remain. And then stakeholder engagement, while sometimes there isn't an opportunity on the what we are doing, there's always an opportunity on the how we are doing it. I think that the IRSS rate alignment is a really good example of the feedback that was provided really changed the way in which we are framing the regulations. And so your insight and feedback will be essential in us being successful in the coming months, but quite frankly, in the coming years, as we collectively work together towards solving this extraordinary challenge. If we can go to the next slide, please. So I want to talk through next steps and public comment opportunities. Next slide, please. So review this slide deck. It will be posted on our LTSS sustainability webpage. I know it's also dropped in the chat here. Go back to, if you haven't signed up for our OCL Digest newsletter, please do that. It is my intention to be sending out regular communication about the feedback that we are receiving on the sustainability actions, how we are addressing that feedback, and how we are moving forward. And we want to truly hear from you. Your voices, your expertise, the view from which you sit will be essential as we move forward. Next slide, please. I want to just flag for you again, resources. Those resources will be posted in the chat for you. That includes our LTSS sustainability webpage. But we also have a healthcare policy and financing sustainability webpage, which has links to the executive orders, the OSPB, Office of State Planning and Budgeting letter, an overview of all the cuts. Today, I only covered long-term services and support. So if you're interested in understanding more about what reductions or changes we're making more holistically, I encourage you to check out that other webpage. And then we have our legislative resource page for those of you that want to get really nerdy. It includes our budget agenda summary and our budget reduction fact sheet. So I'm hopeful that these resources will be helpful to you in navigating some of these changes. If we can go to the next slide, please. Again, I want to remind you of the listening sessions and ask that you use our stakeholder comment form to send us any comments in advance of that. After that, all of the time, we really do want to hear your feedback and want to try to meet you where you're at. We are compiling of what we've heard, and that will also be posted on our Medicaid Sustainability and LTSS webpage, just in case you're interested in sort of what the overarching feedback is. If we go to the next slide, please. Here again are the opportunities to provide comment. They are also linked in the chat, rulemaking and for our official public noticing process. Next slide, please. With that, I thank you for your time. I thank you proactively for your engagement. I thank you proactively for your insight as we look to traverse this fiscal mountain that is before us. I often say that there isn't a community that I would rather work with than this one. You all are some of the best problem solvers I know, and I have no doubt that we will work hand in hand to make sure that as we move forward, we can continue to be proud of this amazing system that we have collectively built for the people that need it right now, and certainly the people that need it in the future. So thank you, and I wish you well as you enter into this week and look forward to being in touch and engaging with each of you.